In a world that is perpetually changing, there is increasing need for steady leadership. Companies demonstrating the courage to address the world's emerging healthcare challenges with passion and compassion. Viatris is redefining the healthcare landscape. We are uniquely positioned to be a source of stability with the commitment, capability, and vision to meet the world's evolving patient needs. Viatris believes in healthcare not as it is, but as it should be. We know the way to provide access to a sustainable, affordable, and diverse portfolio of high-quality medicines, regardless of a patient's geography or circumstance. We are leading the way by providing a versatile, scalable platform that combines best-in-class manufacturing and supply capabilities with innovative solutions that span therapeutic areas. And as a partner of choice, we are pioneering a way to empower companies of any size to leverage our distinctive global healthcare gateway, so products from across the industry and around the world can rapidly and effectively reach patients where they live. We do so with a collective spirit of resilience, driving forward until each challenge is addressed and every opportunity embraced. We are inspired by this moment of shared purpose, because as Viatris, we know the way to empower people worldwide to live healthier at every stage of life.
Good morning and welcome to this industry-sponsored symposium through a CME grant care of Mylan, Philippines. So the topic for this part of the symposium is COVID-19 management pearls and pitfalls. So this are the scope of the discussion. I will be discussing case-based cases with overlapping clinical presentations with COVID-19, its approach and management, and the second speaker will talk about pulmonary complications of COVID-19 diagnosis and management. And this will be delivered by Dr. Aileen Wang. Multiple conditions can present similarly with COVID-19, and in fact, some of which can carry a significant morbidity and mortality. And as the infection becomes more prevalent, as what is happening now in the Philippines among the general population, the other aspect or complication is it can also cause exacerbations of other underlying medical conditions. And this is where difficulty can come up because it's also very difficult to distinguish whether COVID-19 or another disease process is causing the patient's acute illness. That's the reason why that the clinician must not anchor on a diagnosis of COVID-19 and continue to consider other potentially life-threatening conditions. If you look at the stages of the infection or stages of the clinical symptomatology of patients with SARS-CoV-2 infection, which usually starts with an acute infection lasting around 7 to 8 days. This is characterized by acute viral replication and initial host response. Most of those overlapping cases that will be discussed in this particular session will also have the same clinical manifestation. And that's where some of the difficulty here that we need to really differentiate and delineate which among these, or is there the presence of co-infection. So this is your post-acute hyperinflammatory illness. And we also have what we call late sequelae, by which our next speaker will also discuss what are its complications and how to approach and manage such pulmonary complications. I'll start with the actual case, GC, a 35-year-old male from Antipolo, Rizal, who came in because of difficulty of breathing. The presentation started around a month ago as non-productive cough and easy fatigability. And then this was followed 6 days prior to admission with increased frequency of cough. And then because of progressive difficulty of breathing associated with cough, the patient prompted to sought consult and thereby advised admission. Okay. So the patients, these are the initial laboratory of the patient. And if you look at the WBC count, which is quite elevated, but the lymphocyte count is only this low. And The ABG at 15 liters per minute revealed an oxygenation only of 85, so giving us a PF ratio of 105. This patient happened to be HIV diagnosed and not yet on antiretroviral. So a diagnosis of COVID-19 suspect critical was given, and at the same time, possibility of differential here is also a pneumocystis pneumonia. Now, this patient continued to have difficulty breathing, and eventually when we tested the patient for SARS-CoV-2 RT-PCR, it turned out to be negative. But if you look at the chest X-ray, it seemed that it's difficult for us to really rule out the absence of a COVID-19, given that this patient also is immunocompromised. But since this patient, the likelihood that this is severely immunocompromised, especially that this patient has been positive already for HIV with a low CD4 count, and at the same time there was oral candidiasis, then the management was more on pneumocystis pneumonia over that of a SARS-CoV-2. Okay. Both of these diseases present with fever, fatigue, dry cough, and dyspnea. And these are some of the difficulty in terms of really ruling out PCP from COVID-19. And at the same time, when you do chest CT scan, both of these will also show bilateral symmetrical ground glass opacities. Elevated LDH are both indicator of poor prognosis for these two types of infections. But in this patient, the CD4 count is below 200, which is manifested as a cause of the lymphopenia. But again, this is also common with COVID-19. And in fact, leukopenia is most common in COVID-19, although there are cases that reported that leukocytosis can also be present, including that of lymphopenia. Now, what makes this, we think that this is PCP and over that of COVID? Okay? The fact that this patient presented with a more subacute course. Remember, this patient presented with on and off cough already a month ago. And 33% of these patients with PCP usually have at least symptom onset 2 to 4 weeks prior to the presentation. Though COVID can also present with dyspnea, but most of the time, the onset of illness is usually within 8 to 9 days. 95% of patients with pneumocystis pneumonia, the most common presentation is always dyspnea, and that is only present in around 11 to 31% of patients with COVID-19. But the other interesting findings here that is not associated with COVID-19 is the presence of your oral thrush. So what will make us think more of a possibility that this is more of an opportunistic infection rather than of a COVID-19 is the fact that during this time of the year, even with COVID-19, the surveillance for HIV continue. And in fact, from January to June, there were already around 3,752 cases. And majority of those cases are reported also in NCR. And that makes it tricky because NCR is also one of the region where COVID-19 is very high. And this is followed by region 4A at 19%. The age group that is usually common by which this by HIV is between 25 to 34 years old. And this is where our patient also belong. And the fact that 13% of all reported cases among newly diagnosed cases of HIV already present with advanced infection, then that's another important aspect that if a patient came in, it's important that you need to elicit the history of an immunocompromised condition, especially the presence of HIV, because PCP is one of those common causes of severe respiratory infections. Okay, now let's proceed to the second case. This is SF, 20-year-old male from Paco, Manila, and presenting with fever. So the history here starts 4 days prior to admission with undocumented fever. This is followed by myalgia, body malaise, and decrease in appetite. And a day prior to admission, patient still had fever, and at this point in time, also complained of gum bleeding. So these are the initial laboratories. There was slight elevation of the transaminases, But the more important findings here is the decrease in the platelet count at 44,000. Dengue NS1 was negative. The serology, IgM is negative, but the IgG was positive. Okay. So there were two differentials then that was entertained. Aside from dengue with warning signs, we also tagged the patient as a COVID suspect. Okay. Now, why is this important? If you look at the morning post that was published, okay, this was around the late part of June, where they look at the possibility, the danger of risk of missing coronavirus cases amid dengue outbreak. And this particular post mentioned specifically 3 countries where dengue is also very high. Malaysia, Philippines, and that of Singapore. Okay? And this only tells us the importance of why we need to rule out the presence of COVID-19 among those individual or patients who will present with dengue, okay? Or even because of the possibility of a false positive results for dengue due to its similarities with COVID-19. So going back to our data in terms of why the Philippines is one of those countries in Asia where there is a high level of endemicity, and what makes this very complicated because of another pandemic is that our cases for dengue remain very high every year, more than 150,000 cases. There is also higher rate of a population that can also be an important group that are at risk for COVID-19. But what is more important here is that the 4 serotypes of your dengue virus is co-circulating in our country, and there is a continuous transmission in 12 months. Okay, so there is no such thing as seasonal month for dengue. And in 2019, I think this is the time that the Department of Health reported a national dengue alert and eventually was elevated to a national epidemic in August of that year because of an 85 increase of dengue cases compared to 2018. And our case fatality rate was really one of those in Asia, one of the highest. Okay, and that's why when we look at some similarities of dengue and COVID-19, of course, the clinical manifestation exhibited by COVID, 80% of this, especially during the mild to moderate stage of the infection, will always resemble any type of viral infection. The presence of cough, fever, muscle ache, or fatigue with a normal chest radiography is really common among these viral infections. Now, the skin manifestation that is characteristic of dengue, especially during the time that the patient will also present with rashes and petechiae, can also be seen in patients with COVID-19, although uncommon. The hematologic disorders that are also present with COVID-19 can also be present in dengue, like leukopenia, thrombocytopenia, and even derangement of your prothrombin time. But what is really important here is the serological cross-reactivity between SARS-CoV-2 and dengue virus infection, because as what was reported during the first few months of the COVID-19 pandemic in Thailand, where some of their patients presenting with flu-like symptoms and were tested with dengue, because dengue is also endemic in that particular part of Asia. They were all positive for dengue, but again, when they tested the patient with SARS-CoV-2, RT-PCR, all of them are positive. So in fact, they call it as cross-reactivity, and it was SARS-CoV-2 and not a dengue infection. Okay. So antigenic similarities between SARS-CoV-2 and dengue virus can cause this false positive phenomena, especially with your rapid dengue serologic test, IgM and IgG. But looking at clinical symptomatology and some of these laboratory findings that are really characteristic of dengue and over that of there are also important differences. If if there are similarities, there are also differences. Like, for example, dengue. Most of those who will present with dengue, especially with warning signs, may have complications of plasma leakage in the form of clinical fluid accumulation and positive or the presence of mucosal bleeding. Okay? That may not be seen initially with patients with COVID-19. Okay? Most of us experience that in any patients with moderate to severe form of COVID-19 will always present with shortness of breath or what we call the silent hypoxia. Based on laboratory findings, we always note that the more severe dengue, higher risk also of hemoconcentration and lymphocytosis, which is opposite with COVID-19 because you have lymphopenia and normal platelet count in some of these cases. The presence of marked thrombocytopenia and on chest X-ray, the presence of pleural effusion, which is usually common among those with severe dengue, even in adult patients, likewise makes this more leaning towards dengue over COVID-19, where hypoxia is very characteristic, and on chest X-ray there is peripherally located opacities. But again, its effect on dengue, the pandemic, is also has to be emphasized because of a significant burden if the presence of co-infection is common based on healthcare system capability. The complexity of diverse disease severities, prolonged infectious periods, and shared clinical manifestations and pathogenesis have made their diagnosis, treatment, and resource allocation challenging in the sense that you need to have both tests, okay? The dengue NS1 and at the same time the SARS-CoV-2 RT-PCR for you to really differentiate one over the other or document the presence of each of these infection in a single patient. Okay. The other aspect here is the pathophysiological similarities between dengue hemorrhagic fever and COVID-19. So we're talking now of a patient with severe dengue and that of COVID-19 where three pathophysiological overlaps can be present. One is the presence of your plasma leakage, which is driven also by inflammatory mediators by both type of infection. And that's why you'll have increased risk also of hypotension related with plasma leakage. Then you also have thrombocytopenia, although a bit quite different in terms of how thrombocytopenia will occur in dengue hemorrhagic fever, where there is destruction of platelets in the peripheral circulation or an element of possible bone marrow suppression. That's why you have thrombocytopenia. But in COVID-19, this is also present, but not as very common, with possibility that it is because of the viremia that can cause bone marrow or inhibition of bone marrow growth. Now, with thrombocytopenia, there is a direct correlation of coagulopathy in among dengue hemorrhagic fever. That's why the reason we need to monitor also platelet count because of the possibility that it can also contribute to coagulopathy, leading to DIC and severe bleeding, which is one pathway of reason for mortality in patients with dengue. While in COVID-19, coagulopathy is driven by a hypercoagulable state due to viremia, leading to venous thromboembolism and arterial thrombosis, which can also be a cause of complication and possibly mortality among COVID-19 cases. So what should be done in a setting where you also have a higher endemicity for dengue and at the same time with continued COVID-19 transmission? Of course, when you have overlap of the symptoms and difficult to rule it out, then you have to do both the RT-PCR for SARS-CoV-2 and the dengue NS1 instead of doing an IgG or an IgM, because by doing a dengue NS1, then that will really confirm the presence of dengue. You continue to intensify vector control measures even during this pandemic in order to decrease really the cases of dengue. High index of suspicion among patients presenting with symptoms compatible with dengue, especially in areas with ongoing high dengue prevalence like NCR. Okay? And that's why that's the importance of doing surveillance and getting information which barangay or which area is reporting high number of cases of dengue. Now I'll proceed with the third case. Okay, this is another interesting case that somehow will have a very higher overlap of symptoms related with COVID-19. So this is JD, a 20-year-old male from Santa Cruz, Manila, presenting with fever and vomiting. Okay, so this symptom started 3 days prior to admission as fever and headache. And then 2 days prior to admission, patient presented with persistent vomiting and at the same time with LVM. So these are gastrointestinal manifestations that were difficult to rule out also the presence of COVID-19 because it can also present with this same manifestation. But what makes this quite unique is that over that of COVID-19 is that in the history, we were able to get the history of wading in flood waters 13 days prior to admission. And on physical examination, patient is slightly jaundiced and with cough tenderness. So we did the SARS-CoV-2 test in this patient and he was found out to be negative. And if you look at the creatinine here, patient's creatinine is already 992, associated with decrease in urination for the past 24-48 hours. And that's why patient was also tagged as possible severe lepto and at the same time COVID-19 suspect. And this is where the why we did really need to do a SARS-CoV-2 viral RNA examination. And this will only emphasize again why the Department of Health warned us, especially in areas where there were flooding during the typhoon weeks. Okay, and after that, no, because there's also a possibility that leptospirosis can also emerge and be another important differential for any patient presenting with fever, myalgia, or abdominal symptoms that is also common with COVID-19. If I'm going to review again, going back to 2018, okay, cases of leptospirosis in the Philippines, we had 5,000 plus cases with a total death of 505. And during the time, the case fatality rate was computed as 9.65%, with Metro Manila registering the highest reported cases at 1,900 plus and death around 194. But if you look at the red box here are the areas that we said are consistently reporting high number of COVID cases here in Luzon. Okay, you have Region 3, Region 4, and you have NCR. And these are also the areas with currently with sustained community transmission of COVID-19. Okay? Between similarities and differences of leptospirosis and COVID-19, similarities, yes, they have both elevation of transaminases and they can also present with ARDS, both of which are complications of each of these particular infection. One is a bacteria, one is a viral. Maybe the pathway is quite different, but on clinical presentation, presenting with ARDS, it's really difficult to differentiate whether it's lepto or it's COVID-19. The differences here is that among leptospirosis, what is very common, especially for those with severe type, is the presence of oliguria associated with abdominal pain. You have cough tenderness and conjunctival suffusion, which might not be so common patients with COVID-19. Okay, and in the laboratory findings here, you have more of leukocytosis, neutrophilia, and thrombocytopenia. While in COVID-19, you have a normal to a low leukocyte count with lymphopenia as more prominent and a normal platelet count. Well, of course, if you get an inflammatory marker in patients with, or inflammatory markers in patients with leptospirosis, it would always be elevated, just like patients with COVID-19. But more or less metabolic acidosis and chest x-ray or congestion in chest x-ray is quite consistent with leptospirosis resulting from an elevated creatinine or acute kidney dysfunction or renal failure, which is not so common with COVID-19, wherein among severe cases, they always present with hypoxia and the chest x-ray is always consistent with a viral pneumonia. So among the cases, among these two entities, they always look at the complications as the overlap of leptospirosis and COVID-19, meaning what if a patient will present with ARDS. Okay, one, the cytokine storm can be the trigger for the result of the complications in ARDS. At the same time, there are studies to document that these patients will benefit with steroids, especially with your leptospirosis, and now also with COVID-19. And that's why as we go on with the COVID-19 and increasing cases of leptospirosis, let's not forget that we really need to differentiate one over the other and at the same time expect a similarity in the complications. And at sometimes we need to, again, look at other features that may somehow lead us to have a very good differentiation between leptospirosis and COVID-19. Okay, so again, my take-home message here is that the presence of these overlapping symptoms with infections that is also endemic in the country, especially at this point in time of the year, with your PCP, COVID-19, dengue and leptospirosis, then this is something that alternative etiologies should always be taken into consideration while we are pursuing a diagnosis of COVID-19 in order not to overlook if these cases are not because of COVID-19, but because of these also potentially life-threatening infectious diseases. The similar clinical manifestations shared by COVID-19 and this type of infections, which are endemic in the Philippines, is a concern, raising more awareness, okay, to expand our differential diagnosis. Okay? And because of this, this will also pose a big challenge, especially in among clinicians in areas or hospitals with limited resources. So with that, thank you very much for your kind attention.
Our next speaker is a professor of medicine at the UP College of Medicine. She's a pulmonary medicine consultant at the Philippine General Hospital and Manila Doctors Hospital. She's also the co-lead of the UP Manila COVID-19 Research Study Group. She is also a study investigator of the WHO Solidarity Trial. She had her internal medicine residency and pulmonary medicine fellowship at the University of the Philippines Philippine General Hospital. She had her respirology fellowship at the Toronto Hospital. She was conferred by the Philippine College of Chest Physicians as a Distinguished Fellow in the Academe in 2008 and a Distinguished Fellow in Research in 2018. Let us all welcome Dr. Aileen S. David Wang.
Good afternoon, everyone. I would like to thank Beatrice for this great opportunity to speak to you today. And it's a great honor for me to speak with one of my idols, Dr. Jean Solante. And I want to share my screen then. So continuing from the lecture of Dr. Solante, talking about pearls and pitfalls. In managing COVID-19. So we thought that we're going to do this just a little differently right now, and not your usual lectures on COVID. So we wanted to talk about things that make it a little more difficult and a little more challenging, particularly for us frontliners, particularly for us who manage patients in the ICU. And these are my disclosures. So around this time, we have a greater understanding of the pathophysiology of COVID-19. We know that once the SARS-CoV-2 virus gets into our airways and epithelium, it exerts a direct cytotoxic effect and a trophic effect. It causes dysregulation of our renin-angiotensin-aldosterone system, such that we develop tissue injury, remodeling, inflammation, vasoconstriction, and vascular permeability. And endothelial cells are affected. There's damage and thromboinflammation with decreased fibrinolysis, endothelial inflammation, and increased thrombin production. And finally, that dysregulated immune response with very prominent T-cell lymphopenia, inhibition of interferon signaling, and a hyperactive innate immunity, leading later on to what we now call as the cytokine release syndrome. And we now also know that that doesn't happen not only in the thoracic or in the respiratory system, but COVID-19 is a systemic disease. So what we hope to do now is talk about further complications of a patient who already has a severe form of COVID-19. And I would like to take off with this very interesting case that I want to share with you that we saw at the PGH. So this patient was a 24-year-old female, previously healthy, no known comorbidities except that she was pregnant, 36 weeks age of gestation, her second baby. She presented with fever, cough, malaise, dyspnea, and loose stools, and her PCR was positive. So she was admitted for pneumonia, and she also, being a gravidocardiac, was having BP spikes. She had an emergency cesarean section for fetal tachycardia. Luckily, the baby was healthy and negative for COVID-19. And she was given remdesivir and dexamethasone. Around the fourth week of illness, her RT-PCR turned negative, and this was actually done successfully about 3 times, and it persisted to become negative. Unfortunately, she had a very, very rocky course. About 8 weeks in the ICU, and she developed several complications. The first one is the pneumonia progressed such that she needed to be intubated for acute respiratory failure and ARDS. She had several episodes of difficult to treat ventilator-associated pneumonia. We had problems controlling her delirium and encephalopathy. And as you can see from this chest radiograph, about going into her 6th week of illness, she developed a pneumothorax on the left side, requiring a chest tube insertion. And around that time, bronchoscopy actually showed the source of that pneumothorax, a tracheoesophageal fistula at the proximal and lower trachea, and tracheomalacia. So, unfortunately, despite all this and aggressive management, around the 8th week of illness, she succumbed to septic shock from VAP due to an MDROA Bomani, complicated UTI, and gram-positive bacteremia. This was a 24-year-old young patient, previously healthy, no known comorbidities, except the fact that she was pregnant. It was really heartbreaking for us to have a mortality like this. So if this was plain and simple community-acquired pneumonia, she should have been discharged from the hospital right away, right? So, and the question that goes to our mind is, what else could we have done for this patient? Can COVID-19 per se be a risk factor for mortality and all these complications developing? Now, a recent study from the Veterans Health Administration in hospitalized patients involving around almost 4,000 patients. What they showed was, compared with patients, historical comparison, hospitalized with flu, indeed, hospitalized COVID-19 patients had a higher risk for 17 complications and 5 times higher risk of dying in the hospital. And my next slide will show you those different complications: respiratory, cardiovascular, hematologic, neurologic, endocrine, renal, and others, and showing you the risk ratios compared to patients who were admitted for flu and pneumonia. So very high complications from COVID. And a recent meta-analysis published just a few months ago shows us that in 30 observational studies covering more than 6,000 patients, the most common critical complication is still ARDS in about a third, and the rest are usually cardiac in nature, and I'm sorry, that should be acute kidney injury. So at this point, in the next 25 minutes, allow me now to talk about the thoracic complications, and I hope I'll be able to provide you with some pearls how to avoid the pitfalls in managing these complications. The first one is ARDS, leading to acute respiratory failure. So again, based on our pathogenesis, with SARS-CoV there in our airway, the problem will be the effect on our alveolar type 2 cells, where there is apoptosis and dysfunction, and this can lead to three things. One is reduction in surfactant that can lead to atelectasis, and because we have less progenitors of the AT2, then we cannot replace our our alveolar type 1 cells, and that inflammation that we're already familiar with lots of immune cell influx and capillary leak. So clinically, the patient will present with ARDS. Pathologically, what we will see is diffuse alveolar damage as a consequence of that significant alveolar epithelial injury. My next slide was published just a few days ago, and it's a very interesting study. It looked at ARDS from usual non-COVID cause and due to COVID-19, and comparing the innate and adaptive immune response. And what this study by Wang et al. Showed was that patients who developed COVID-19 ARDS exhibited a higher day 28 mortality. They did show that profound and sustained global lymphopenia that has been shown in prior studies. And the authors next called it, these patients exhibited a very interesting or a characteristic chemokine signature, wherein there's higher serum concentrations of all the various cytokines and mediators. And together with an increased concentration of the CXCL10 and IP10, the GM-CSF, and a higher nasopharyngeal viral load, these were all associated with higher 28-day mortality. So it tells us maybe, can COVID-19 ARDS be different from non-COVID ARDS? If we will look at all the beautiful pictures regarding this, we know that comparing the classic ARDS with COVID-19 ARDS, it's the same. They have alveolar interstitial capillary unit involvement similarly. And in both types, there is upregulation of the pro-inflammatory biomarkers. There's increase in capillary endothelial permeability and increase in inflammatory cells in the vascular and alveolar compartments. However, in contrast to classic ARDS, what we will see in COVID-19 ARDS, there is, I mentioned it earlier, lower expression of our interferons and increase in thrombotic mediators. And comparing now mild to severe ARDS, all these things become exaggerated. We see higher neutrophil count and neutrophil activity, and further increase in these inflammatory biomarkers and thrombosis, and greater monocyte and lymphocyte activation, and more damage to that alveolar interstitial capillary unit. That will lead to diffuse alveolar damage, that will lead to ARDS. So in the clinics or in the ICU, we still use the Berlin definition of ARDS. It was published 2012, and you all are familiar with this. We classify the severity of ARDS from mild to severe according to the PF ratio, and as we remember, higher mortality for the more severe type, the lower PF ratio. But the thing is, even for patients with typical quote-unquote or classic ARDS, it is a heterogeneous condition. So just showing you CT scan pictures of a patient who had the clinical feature of ARDS, showing you the inhomogeneous involvement of our lung parenchyma. And this will depend, of course, on the days following the injury, what stage the patient is already in, and the type of pathogenetic mechanism that's already now involved. Now, Gattinoni et al. Introduced that concept of, and his group, that concept of baby lung sometime in the mid-1980s. And what they actually meant was, in patients with ARDS, the non-dependent ARDS, non-dependent higher portion is aerated, in contrast to the one that has pulmonary edema. So the suggestion was, if you shift the patient, turn that patient around, like in a prone position, we will be able to aerate those previously blocked airways and alveoli. And indeed, as you can see from this CT scan, this time the anterior portion is the one that already will show the infiltrates. And I will now remind you about that sponge lung concept, such that with movement or with functional capacity, we will see that the dependent area will be able to absorb or sponge off that edema. And the one that's superior can become aerated. And when the patient is supine, we will go back to the usual concept. So classic ARDS is heterogeneous. How about COVID-19 ARDS? At the beginning of the lockdown here in the Philippines, there was one major publication that woke all of us crit care people. So by Gattinoni et al. Again, published in March 30, 2020, wherein, and the title of their publication was COVID-19 does not seem to lead to a typical ARDS. So they were talking about their experience of their first 16 patients in northern Italy, where they noted that in contrast to your usual ARDS, there was a dissociation between the relatively well-preserved lung mechanics and the severity of hypoxemia. So if you can see here, a patient with the respiratory system compliance of 50, the shunt fraction was about 0.5. And this kind of wide discrepancy, we virtually never see in the most usual forms of ARDS. Now, they surmised, or they hypothesized, that the relatively high compliance will indicate that a well-preserved lung gas volume can be seen in these patients, in sharp contrast to expectations of a severe ARDS. And two possible hypotheses: number one, loss of lung perfusion regulation, and number two, hypoxic vasoconstriction. So imagine this publication coming out at the time when we were still grappling with what to do with our patients in the ICU. We had no evidence to hold on to, and we were really basing everything on our experience. A month later, Gattinoni's group proposed that there may be different phenotypes of COVID-19 pneumonia. The first one is the L type, where there is low elastance or near normal compliance, low ventilation perfusion, low lung weight. On CT scan, we'll just see peripheral and subpleural GGOs. There's low lung recruitability. And on the other hand, there's the other type that his group proposed is the H type of pneumonia. And this time, these are patients with high elastance due to increased edema. There's significant right to left shunting due to perfusion of non-aerated dependent lung regions with increased edema. And then there's high lung weight because of lots of infiltrates commensurate to severe ARDS. And those non-aerated tissues, there's high lung recruitability. So in their cohort, they saw that L type is usually seen in the early course of the patients, but for some of the patients, these can remain unchanged throughout their clinical course. On the other hand, a certain proportion of their patients shifted from the L type to an H type pneumonia, and that all depended on what was happening in the lungs. Was capillarily continuing, causing lung edema, causing impaired gas exchange, and thus increased respiratory drive. And we already know that a patient with huge inspiratory efforts, that effort itself can cause a patient self-inflicted lung injury, which makes this vicious cycle go on. So the recommendation was perhaps, even if they have ARDS and they're being treated in the ICU, the management may be different. For L-type pneumonia, increased FiO2, so high flow nasal cannula and invasive ventilation might work. If they're intubated, they're supposed to respond to a higher tidal volume, 8 to 9 ml per kilo, compared to the usual Ards net recommendation of 6 to 8. PEEP is usually not much requirement, less than 10, and maybe there's no need to prone these patients. On the other hand, H-type pneumonia treat a severe ARDS with higher PEEP, with proning, and the more advanced type of ventilation, and even including ECMO. So that was sometime in April 2020. But since then until now, this concept is actually already being disputed. And my next slide, I want to show you a very nice review by the FLAIR team from MassGen, showing the various observational cohort studies that were conducted in North America. And let me just give you a summary of these data. What they showed, in contrast to the Italian experience, these observational cohort studies demonstrated an internal uniformity and actually a similarity to prior ARDS cohorts. They documented the near universal presence of that impaired gas exchange with a PF ratio of less than 200 and those bilateral pulmonary infiltrates. And frequently seen is low respiratory system compliance. And based on their experience, there are some important points that we can take home from these. Number one, severe COVID-19 can still be optimally treated by a strategy that will minimize distending pressures and lung stretch, the techniques that we already know. Number two, COVID-19 ARDS should be treated with the best established evidence-based protocols as applied to other causes of ARDS. So our societies have guidelines regarding this, including our local ones. Number three, and I think this is very important. At the outset, they were saying the mortality rate of patients who are intubated goes as more than 70%. But subsequent studies show this to be much lower. So if you will see here, mortality rate at worst is about lower than 50%, but most of them less than 20%. So mechanical ventilation properly done is still saving lives. And finally, that observation of quote-unquote happy hypoxia, wherein the patients will present with significant hypoxia or hypoxemia, but they're hardly complaining of dyspnea. And the response to that recently now is we know that dyspnea is not always due to hypoxia, and this concept is not specific and not new. It's not specific to COVID-19. We know that from our physiology lectures before, dyspnea has a complex relationship to hypoxemia, and hypoxemia alone is a weak stimulus for dyspnea. And I will end this talk on ARDS by a very nice review by Eddie Fan et al., published The Lancet. I think this was last month. And let me just quote them. COVID-19 associated ARDS, early studies reported or suggested distinctive features apart from historical ARDS. But emerging evidence indicates that the respiratory system mechanics of our patients, whether or not they have COVID-19, are broadly similar. And therefore, the same as the recommendation of the MassGen group, in the absence of evidence to support a shift away from the current paradigm of ventilatory management, they strongly recommend adherence to evidence-based management informed by bedside physiology as resources permit. So how do we manage ARDS? So this publication is one of our Bibles, 2012 published, and showing you the different strategies that we employ, whether the patient has mild to severe ARDS. And these are still the same things that we're doing. And we always have to find a balance. So we want to avert invasive ventilation and potential for ventilator-induced lung injury. On the other hand, we want to prevent the harms from prolonged strong inspiratory efforts resulting in PCLE, that increased lung stress and the risk of delayed intubation. So in the ICU, we're always trying to find a balance between these. And that's my short update on ARDS. Next, I want to talk about tracheal complications, what our patient had. And I wondered, how common is this? And I actually found a publication 2 weeks ago, published in the JAMA ENT, and a retrospective cohort looking at patients on mechanical ventilation and with COVID-19, and they were compared with matched controls. And the results were pretty interesting. What they showed, the COVID-19 patients had higher incidence of developing full thickness tracheal lesions and tracheoesophageal fistula. Odds ratio 38. And it isn't uncommon. Almost half of their patients actually develop tracheal complications. And how did their patients present? Pneumomediastinum in 71%, pneumothorax in 43%, with or without subcutaneous emphysema. So, what is the lesson for today? Please consider tracheal complications when we're managing our ICU COVID-19 critical patients. Why do they seem to be more common in COVID-19? So the authors propose the following possibilities. Number one, that pronation maneuver. The early implementation can increase the cuff pressure on the tracheal walls. Number two, the pathogenetic mechanism that involves prothrombotic and antifibrinolytic state, which will cause microvascular injury and necrosis of the tracheal and the esophageal mucosa. And finally, we can have high viral replication. The patient has a high load with the tracheal epithelium that weakens the mucosa. And some other possibilities, the use of systemic steroids, as we know, can cause mucosal atrophy and alter normal healing, including that of the trachea, particularly if there's already irritation or wounds from suctioning and from intubation. And lastly, that hypoxic state itself can affect the tracheal mucosa. So what is my take-home message here? So the recommendation, high index of suspicion is important. Consider it, almost half of their patient in this group from Italy. And recommendation, if you have it, monitor the tracheal cuff pressure regularly, particularly when the patient is in the prone position. Next, pleural complications. How often is pleural effusion or pleural thickening? So this is a very nice review by Parcell et al. So they said, ubi fumus, ibi ignis. So where there's smoke, there's fire. And just showing us some of their reviews showing pleural thickening. It's not uncommon, as high as 52% in one series. On the other hand, pleural effusion, about 5%, so not that much, but it can happen. But what we seem to understand now is there is both direct and circumstantial evidence already that SARS-CoV-2 is responsible for the generation of pleural effusions. And later on, I'll show you secondary spontaneous pneumothorax and pneumomediastinum. So it may not be related to just the other problems of the patient, whether it's a superimposed bacterial pneumonia or a congestive heart failure problem or hypoalbuminemia due to sepsis. But what we need to look at is pleural effusion seems to be more common in critical patients and it's a poor prognostic indicator. We know that SARS-CoV-2 can cause pleural effusion in that it's been detected in pleural fluid specimen. Now, how about pneumothorax? Let me share with you some cohort studies. This one, in my slide, is done at Temple University in Philadelphia. And they looked at their patients who were admitted with SARS-CoV-2 and actually very low prevalence or incidence, 0.66%, 6 out of their 902 patients. And the mechanisms they proposed, either it's a mechanical ventilation complication or those structural changes due to COVID-19. But what they saw was that pneumothorax is higher in patients with ARDS, particularly they're on mechanical ventilation for a long duration of time. And as you can see from their 6 patients here, 4 out of their 6 patients died. And the size of the pneumothorax from small to large, but they all required chest tube intubation. And the time to onset of the development as early as 1 day to as long as second week. The next study is a retrospective multicenter study in the UK. This is actually the largest reported series that I can share with you. And what they saw was, in general, among their cohort, 1% of their COVID-19 patients in the UK developed pneumothorax. And they looked at these 71 patients from 16 UK centers. 60 had pneumothoraces, 6 in addition to pneumomediastinum, and 11 had pneumomediastinum alone. And what they saw, it can occur without pre-existing lung disease or mechanical ventilation. And among their patients, 2/3 survived, but poor prognostic factors include age and acidosis. And just showing you a picture of one patient developing a pneumothorax, and right before that, a CT scan's actually already showing you this lucency here, or thin-walled bullous lesion with an air fluid level, and cystic spaces subpleurally. And if you will look at our photomicrographs, we will see a lot of fibrosis here, and you will see plugging, and on the last few photomicrographs, you'll see some connections or channels leading into the airways. So pneumothorax may not be as common, but it is a significant problem, and it can carry a poor prognosticator indication. The fourth complication I want to share with you are, interestingly, bullous lung disease and pulmonary cavitations. How often are they in COVID-19 pneumonia? So this is an interesting case report of a 60-year-old male who developed sudden onset right-sided chest pain and dyspnea 11 days after admission due to COVID-19 pneumonia, and about 8 days while on 8 days on CPAP. And you will see baseline chest radiograph, just these alveolar infiltrates. But later on, this pneumothorax, which was actually complicated with some thickening already of the visceral pleura. And what they showed, other than the severe COVID-19, their intensive investigation did not reveal any other underlying disease that could trigger that rapid deterioration of the lung parenchyma. So can COVID-19 produce bullous lesions and cavitations? The next slide, I'm showing you another interesting case series, this time from Cleveland Clinic, Abu Dhabi, published a few months ago, where they were able to see 12 of their 689 patients na admitted, or that's about 1.7%. They all had severe disease, and they all developed de novo pulmonary cavitations. What they saw in their follow-up chest radiographs and CT scans, the cavities tended to form in areas of the lungs where the GGOs were seen in early stages, and then morphing into more dense consolidation, and later developing necrotizing and ultimately cavitating lesions. So ergo necrotizing pneumonia. And if you will look at their various series here, the cavity sizes are different. They're typically bilateral. There doesn't seem to be any upper lobe predisposition. And on the other hand, they're not sure if this pneumothorax among these patients with critical care and severe COVID, if it's related to secondary infections, because as you can see from the table, many of them had invasive fungal infections, and many of them also grew significant organisms related to a hospital-acquired pneumonia. Okay, so that's for bullous lung lesions. And in my last few slides, let me just talk about secondary infections. And you know this more than I. But how frequent are co-infections and the development of secondary infections? Let me share with you just very recent systematic review published in July by Langford et al. And what is meta-analysis of 24 studies involving more than 3,000 patients? 3.5% co-infection. That means the infection was already there on presentation. Only 14.3% of their patients developed a hospital-acquired pneumonia. And yet, at least 71% of their patients were given antibiotics. So I hope PSMID will be able to give us guidelines on antibiotic stewardship. And I'm sure you have lectures on this already. And that's what I can share about that. And last two short complications that are interesting. I'm not going to talk about the cardioembolic complications, but the thromboembolic complications. So at the outset, we now also know that because of the viral endothelial insult leading to endothelialitis, hemoconcentration, and the stasis from bed rest by Virchow's triad, you can have these problems already that promote in situ pulmonary thrombosis. This can become progressive, then extensive, and leading to diffuse alveolar damage. And this thrombogenic phenomenon, as we remember, can predispose to pulmonary embolism. How frequent is pulmonary embolism? Unfortunately, there are various reports, but I just want to share with you some studies. This one in Lille, France, where they showed that in their ICUs, they noted double the increased incidence of acute pulmonary embolism in their patients with COVID-19 compared to their historical controls. And this despite prophylaxis with unfractionated heparin and low molecular weight heparin. So the variable report of incidence of acute pulmoembolism in hospitalized patients, but the studies are mostly retrospective in nature. So the range is between 1.9 and 8.9%. It increases if the patient undergoes CT angiography. I guess they're already suspecting pulmoembolism. But another interesting thing about COVID-19, in 80% of those patients in France, they had no detectable source from a lower extremity DVT, suggesting that the thrombosis occurred in situ. But they showed that higher incidence of APE was in those patients who had ARDS to start with. And my next slide will show you the various COVID-19 coagulopathy can overlap with the diseases that we are already seeing with coagulopathy. Sepsis-induced or disseminated induced coagulopathy, hemophagocytic syndrome, antiphospholipid syndrome, or even thrombotic microangiopathy. And as you can see from my figure here, COVID-19 coagulopathy can overlap here, but it's not a perfect match. So finally, my last few minutes, sorry for I went a little over time. Allow me to share with you the latest experience on post-COVID-19 lung damage. A very nice study from the Dutch group published November 29, they looked at 101 non-critical Dutch patients who survived not critical, so moderate to severe pneumonia, and were followed up 6 weeks post-discharge. And what did they see? In these patients, 71% still manifested with low diffusing capacity, particularly those with severe pneumonia. Next, on pulmonary function testing, about 1/4 of them showed obstructive airways abnormality, and about 2 out of 20% showed restrictive ventilatory defect. The other thing about these patients, a significant proportion of them showed depression and anxiety, more than 10% of them. And finally, how about quality of life? If you will look at the various domains of the SF-36, except for bodily pain, significant impairment was found. And FEV1 and DLCO, the levels, will show significant positive correlation with the dyspnea scores and the quality of life scores. What happens to these patients? Unfortunately, we do not know yet. Can they mimic what happens to those patients who developed SARS? Now, interestingly, early this year, there was a publication on SARS survivors. These were medical staff, 71 of them, who actually completed 15-year follow-up in China. And what did they see among these patients? So what they saw, the percentage of pulmonary lesions on CT scans diminished from 2003 to 2004 and then remained stable thereafter until 2018. And between 2006 and 2018, their proportion of patients who showed interstitial changes and had improved pulmonary function were unfortunately lower than that who didn't have lesions to start with. And fortunately, for the majority of the patients, pulmonary interstitial damage and functional decline caused by SARS mostly recovered with a greater extent of recovery within 2 years after undergoing rehabilitation. So, allow me to finally talk about pulmonary fibrosis. Know that from acute chronic inflammation with the damage and overexpression of our cytokines, we can activate our fibroblasts and myofibroblasts, leading to excessive deposition of collagen in our extracellular matrix. How often is fibrosis post-COVID? So one of the first studies in Wuhan showed that fibrotic changes can occur early, in about 33%. And this is more likely in those patients with the advanced disease. Another study showed that a series of 4 patients who died of COVID-19 pneumonia, and pathologically, what they showed, aside from diffuse alveolar damage, indeed there's significant fibroblastic proliferation and deposition in the ECM and fibril. And some patients in China actually underwent lung transplantation. And the explants, when they looked at them in these 3 patients, they showed extensive fibrosis of the lungs. So we know that a certain proportion of patients, we do not know yet why, but they can develop significant fibrosis. So what to do with these patients? Actually, right now, there are already RCTs on antifibrotic agents like nintedanib and pirfenidone already either registered or have started. And this is my last slide, and I wanted to share it with you, and I thought it's pretty useful. It's a follow-up algorithm for patients who developed severe to critical care COVID-19 pneumonia but survived it. So recommendations, at least teleconsult, 4 to 6 weeks of discharge, 12 weeks at least a chest radiograph, a pulmonary function test if possible. If normal, then we can discharge that patient. On the other hand, if these are abnormal, particularly if there's evidence of pulmonary vascular disease, then we should do at least a CT scan with angiography or echocardiogram as indicated. And ILD or PVD, then refer further to our specialists. And that is my last slide. Sorry, it took long, 40 minutes. I hope I was able to cover this, and I hope I was able to give you some pearls how to avoid these pitfalls of when these complications of COVID-19 develop. So thank you very much, and thank you also again to our infectious disease specialists for your care. So thank you very much.